Hello, I'm Rick Barron, and I'm going to review with you the 10 neuropathic patterns that patients with neuropathic disorders can present with. The goal is to put patients in one of these 10 patterns so that you can more effectively diagnose and manage the patient. Pattern 1, NP1, is symmetric proximal and distal weakness with sensory loss. This is the pattern for classic acquired demyelinating neuropathies, and the diagnosis in this case will either be Guillain-Barré or CIDP, depending on the temporal evolution of the case. Pattern 2, or NP2, symmetric distal sensory loss with or without weakness, is the most common general neuropathy pattern that you will see, and the diagnosis in this case is usually going to be diabetes or cryptogenic sensory polyneuropathy, otherwise known as C-SPAN. But drugs, toxins, connective tissue disease, hereditary disorders can also present with NP2, as can a variant of an acquired demyelinating neuropathy, DADS. NP3 is asymmetric distal weakness with sensory loss. If this is in a single nerve, such as median or ulnar, or a single root, then you're dealing with a compressive mononeuropathy or radiculopathy. But if multiple nerves are involved in an asymmetric pattern, then that is mononeuritis multiplex. And in this case, the differential includes vasculitis, HNPP, and also another variant of acquired demyelinating neuropathy, MADSAM. NP4 is asymmetric proximal and distal weakness with sensory loss. So the whole limb is weak with sensory involvement. With this pattern, the lesion is either going to be multiple roots or polyradiculopathy, or the plexus, or a combination, radiculoplexopathy. The most common causes in this pattern are going to be diabetes or diabetic lumbosacral radiculoplexopathy, or cancer invasion into the meninges or the plexus. And it can also be idiopathic, such as in the Parsonage-Turner syndrome. Pattern 5 is asymmetric distal weakness without sensory loss. This is the motor neuron disease pattern. So if there is upper motor neuron findings, then the diagnosis is usually, unfortunately, ALS. If there are no upper motor neuron findings, then this could be progressive muscular atrophy, another sporadic form of acquired motor neuron disease, which is essentially ALS. But it also could be multifocal motor neuropathy, a treatable disorder, another variant of an acquired demyelinating neuropathy. Pattern 6 is symmetric sensory loss with or without distal weakness and upper motor neuron signs. So this essentially is the NP2 pattern, but with upper motor neuron signs, which means that there's also myelopathy. So this is the myeloneuropathy pattern, and in this case, one has to do an intense search for B12 and copper deficiency, and sometimes other disorders. NP7, or pattern 7, is symmetric weakness without sensory loss. So if the weakness is proximal and distal, then this is a spinal muscular atrophy pattern. If the weakness is only distal, then the diagnosis is hereditary motor neuropathy, previously called distal SMA. Pattern 8, which I call focal midline proximal symmetric weakness, will either present with neck or trunk extensor weakness, bulbar weakness, or shortness of breath, diaphragm weakness. And this is usually due to motor neuron disease or ALS. Pattern 9, a rare pattern, asymmetric proprioceptive loss without weakness, severe ataxia of a limb or very asymmetric ataxia and proprioceptive loss. And this is due to a sensory neuronopathy, a dorsal root ganglion disease. And the diagnosis usually is going to be cancer from a paraneoplastic disorder, but it also can be occasionally due to connective tissue disease or toxicity, and rarely idiopathic. And finally, pattern 10, or MP10, is autonomic dysfunction in which the patient will have symptoms of orthostasis or impotence or abnormal GI motility or sweating, and that is commonly seen in diabetes, in the rare neuropathic disorder amyloidosis, common in Guillain-Barré, and other disorders as well. So once you have placed the patient in one of these 10 patterns, and we carry around our laminated card in the clinic to remind us of what the patterns are, then you can more accurately narrow down the diagnosis of the patient and effectively treat your patient with a neuropathic disorder. I hope this brief summary of the 10 neuropathic patterns has been of help for you in your practice.